In this special topic webinar, we'll provide some tips on working with families of depressed patients. We'll be discussing the reasons for working with families, a framework for thinking about family functioning, some of the most common challenges, and suggestions for responding to these challenges. Working with the families of your depressed patients is important because the family environment and family challenges impact the patient and can affect their mood and recovery from depression. In turn, the patient's depression can impact relationship with spouses, adult children, and grandchildren. Often these family members are motivated to help improve depression and outcomes and can therefore be strong allies in treatment. This in turn can make your work all that much more rewarding. Very briefly, to give you a framework for thinking about family interactions, the McMaster model of family functioning outlines 5 areas of functioning. The first is problem solving, or how well the family or couple successfully resolves challenges that come their way or arise between them. It reflects how well families and couples work together to solve those challenges. Roles reflects the manner in which families and couples deal with the challenges of day-to-day living, particularly as responsibilities shift due to changes in health and functioning as people get older. Behavior control and safety indicates the extent to which families use good judgment with respect to safety issues. Obviously, as people get older, challenges around mobility, stair use, lifting, and fall risk become more important. Particularly in home care, you often see these issues arise firsthand while in a patient's home. Emotional responsiveness reflects how well couples and families deal with difficult emotions that arise in the relationship. This is particularly important with depression treatment, as many of the symptoms that come with depression can be a challenge for other family members. Often you see a vicious cycle in which depression, for example, causes frustration and sadness in other family members, which just worsens the patient's isolation and depression. So this is an important domain in depression treatment. And finally, on the other end of the emotional spectrum is emotional involvement, or how well the family or couple share positive moments together, enjoy being together, and share enjoyable activities. Often when one family member is depressed, these areas of intimacy suffer, which can lead to a vicious cycle of negativity, withdrawal, and worsened depression. As suggested in the previous slide, depression can negatively impact many of these areas of functioning. For example, depression can reduce emotional connection and increase withdrawal, decrease communication and problem solving, increase individual and family isolation, disrupt practical household functioning and finances, increase guilt, anger, and sadness, and increase anxiety and depression among caregivers. So, working with families provides an opportunity to help with many of these challenges. For the patient and the family, providing education and guidance on depression can improve attitudes toward depression and depression treatment, reduce family conflict, decrease the burden on family members, and improve patient functioning. In your work, you may see improvement in patient mood, improvement in treatment adherence for other medical conditions, and you may even see improvement in health outcomes. So, what can you do to help and support both patients and their family members as you focus on depression treatment? First is empathize with the patient, their family members, and their circumstances. Make sure not only the patient but also family members receive educational materials. This is an important first step toward engaging the family in supporting depression treatment. Be aware of life changes and how the family has responded. For example, patients who lose functioning and abilities following a medical event such as a heart attack or stroke are at greater risk for depression. Encourage behavioral activation exercises to break the cycle of depression. Focus on self-care and support, increase social support if possible, enjoyable activities, and treatment adherence. I'll be talking more about each of these areas in the following slides. One of the most important things you can do is empathize with your patients, their families, and their circumstances. Often with these patients, depression has been a problem for a long time before you even walk in the door, and it is important to be sensitive to their particular circumstances. Loss is often a common theme as people struggle with decreased mobility, functioning, independence, and social support. Increased isolation may compound these difficulties, Again, this is often a significant challenge with homebound elderly. Patients may have frustration and anger because of their limitations. Family members may have frustration and anger at the patient, especially if they don't understand the nature of the depression. And everyone in the family may feel helpless to do anything about their circumstances. So it's very important to empathize with each family's unique circumstances. To the extent that you're able, it's very important to include family members in education about depression. This is a critical first step in recruiting their assistance in recovery. Clarify that depression isn't just sadness, but is a pervasive and persistent mood disorder. Depression affects all members of the family, and therefore treatment should include family members as much as possible. When discussing goal setting and self-care for the patient, inform spouses and adult children that they can help with identifying goals and encouraging adherence. Make sure family members take care of themselves and that they are caring for their own health and well-being and finding support. And encourage family members to communicate with you and other professionals. Be aware of significant life changes that your patients are struggling with. Often the very conditions you're being brought in to treat are related to the challenges that these patients are facing. How well they cope and adjust can impact the recovery from depression. For example, staying fixated on their past abilities and wanting things to be the way they used to be can greatly increase feelings of helplessness. Patients often do better when they can accept their limitations, whether physical or functional, but still maintain hope that they can have a good quality of life even within these limitations. For example, I know of a patient who was a lifelong fisherman and often went to fishing competitions. But due to pain and mobility problems, he was no longer able to go fishing. Instead, he got trained to be a judge in these competitions and in this way was still able to maintain his involvement in a sport he loved. It's important to be aware of these kinds of limitations that patients are struggling with and how well they're coping with these challenges. When conducting follow-up visits, as much as possible include family members in patient care. Learn about the patient from them and about their relationship with the patient. Be sure to include them in education about depression and expect to repeat a lot of this education on follow-up visits. Be aware of how the family members are doing and consider referring them to community-based services for additional support and services. So let's look at a few concrete cases to get a better idea of how family issues play a role in depression treatment and recovery. In this case, Mr. Bennett is the identified patient, a 68-year-old gentleman who lives with his wife of 45 years. Several years ago, he suffered a serious stroke that affected both his cerebellum and brainstem. As a result, he has suffered from left-sided weakness, ataxia, and slowed and slurred speech. He's been through extensive inpatient and outpatient physical therapy over the years, and at this point is not expected to show much improvement. But he has been continuing with some outpatient PT and pool exercises at the local YMCA. He's receiving home health services following a fall right now. There was no significant injury during the fall, but he was brought to the hospital at his wife's request because she was becoming increasingly concerned about weakness and balance difficulties, increased agitation and anger, and saying he'd be better off dead. He was admitted to the Geri-Psych unit and diagnosed with vascular dementia, with executive dysfunction, disinhibition, and comorbid depression. For the depression, he was started on 20 milligrams of Prozac. He was discharged to rehab for 2 weeks after the inpatient stay, and then home for outpatient physical therapy, skilled nursing for a pressure wound, and CNA services. As I said, the couple has been married for 45 years. They currently live in a condominium apartment and have been able to make some modifications for his disability, but they both report that the condominium board has been very difficult to deal with. Mr. Bennett is a former chemist who was very successful as a project manager for a pharmaceutical company. Since his stroke, he's been unable to return to work as a chemist, and at the moment is working part-time at a local school, mostly helping with data entry. Mrs. Bennett is a retired real estate agent. She reported that she had to retire following his injury because she needed to stay home to take care of him. She has also taken over almost all household activities. She does the shopping, the cooking, finances, home care, and much of the personal care for him. They reported that socially, they do attend church every week and are active in a very busy and supportive church, but otherwise they stay home together and don't do much. They have 2 adult children, a daughter who lives nearby, and a son who lives in a neighboring state about 7 hours away. They've always had a good relationship with their children, but there is more tension with their daughter's family because they don't get along very well with their daughter's husband. This has been an added difficulty for the couple, as they would like to see their 3-year-old grandson more, but only get to see him about once a month. They have no tensions with their son's family, but since he lives so far away, they don't get to see him often. Prior to Mr. Bennett's stroke, the couple lived together in their home in Ohio, near both of their jobs. After the stroke, they moved near their daughter to be closer to her and because it was an area of the country that they had previously lived. They'd always been active in church and community activities and traveled extensively together, especially after the children went away to college. Generally, they divided household responsibilities in a traditional way. He took care of finances and home repairs inside and out, and she took care of meals and cleaning. Overall, they described their marriage as very strong over the years and said they still loved each other very much. During the visit, you observed them holding hands at times and Mrs. Bennett rubbing her husband's back. You verbally administer the PHQ-9 to Mr. Bennett. His score is a 19, which is in a moderately severe range. He acknowledges that he sometimes thinks he'd be better off dead, but he doesn't have these thoughts as often as he did prior to his hospitalization, and he denies that he would ever act on those thoughts. He also has had much less anger and agitation and thinks the Prozac may have helped with that. Later on during the visit, the wife pulls you aside and confides that she's also answered positive to most of the questions, and says she thinks she might be depressed too. She tells you that she feels completely overwhelmed, both because of the new work she has in taking care of him, and because she feels that he's not trying to do the things that he can do. She notes that he's become very afraid of falling and breaking his hip. Both of them tell you that everything seems like work and that life has just stopped for them. So, if we go back to the 5 areas of functioning, it's easy to see that pretty much every area has been impacted by this event. When it comes to problem solving, as they put it, they are effectively stuck. On a day-to-day basis, the wife is taking on most of the responsibility for responding to challenges in the home, his health, and care for both of them. On a larger scale, they have so far been unable to find a way to problem solve on how to have a better quality of life. With regard to roles, Mrs. Bennett has taken on almost all responsibilities. She is overwhelmed and Mr. Bennett feels useless. If you think about behavior control and safety, Mr. Bennett initially was having problems with agitation, anger, and subsequently a fall. But now he's so afraid of falling again that he's not getting up much at all. So there may be a problem of over-control here. With both emotional responsiveness and emotional involvement, there is also a mixed picture. On the positive side, they've had a strong relationship over the years prior to the stroke and can still show affection by holding hands in physical contact. However, as they have put it, in many ways life has stopped and they haven't been able to enjoy their lives together very much. So what this couple needs may be more than can be accomplished in a wound care visit, but there are some things you can do to support them, provide information and resources, and by doing so, help maximize both of their chances for improving. First, as mentioned before, just empathizing with their dramatic life changes can go a long way. Reflecting their feelings of loss, grief, and frustration can help them feel less isolated in these challenges. This can be particularly important with visiting nurses who are coming into the home and seeing their world firsthand. It's important to include Mrs. Bennett in your education about depression. Grief is a normal response to loss, but when it turns into depression, it becomes an illness that needs treatment. You can point out that depression may be affecting the relationship between the two of them, making it more difficult for them to connect, enjoy any of their time together, and have the energy to make changes. And it's important to include the wife in treatment and behavioral activation goals. Try to brainstorm with them about modifications of their activities that they used to enjoy. Since the wife told you that she thinks she may be depressed, it's okay to ask her if additional support might be helpful. Since you will have just educated them about depression as an illness, perhaps the wife might consider an evaluation by a mental health professional to help herself. She could also perhaps gain additional support from her family or church, not only emotional, but perhaps also with instrumental activities, like care for her husband so she can have some time to herself, or help with household duties. A common theme with families in these circumstances is that life is never going to be the same. This may be true, but it doesn't mean that life is over. A large element of moving forward is coming to accept the new normal, that some things can't be changed, but they can still enjoy their life given these changes. You should also expect to revisit these themes during follow-up. During follow-up visits, you'll conduct the recommended follow-up procedures of assessing symptom severity, assessing medication dose, response, side effects, and adherence, and following up on behavioral activation. But in this context, you can also include Mrs. Bennett in the dialogue as you did before. You can ask whether they are doing more things together as a couple, whether she is getting additional support, and if she got an evaluation for depression. Expect to repeat education about depression as an illness and the treatment guidelines. Also, make use of your community resources for care. It may be the case that either or both of these clients need more intensive outpatient mental health services or social services, and it's important to be able to connect them with this care. Now let's look at a different case. Mr. Moore is an 82-year-old widowed man. His wife died 4 years ago after being married for 51 years. He now lives alone in his single-story home that he has lived in for more than 40 years. He has a number of medical problems. He had a TIA 3 years ago, and neuropsychological testing indicated mild cognitive impairment with deficits in fluency, word finding, planning, and organization. These deficits have not worsened in the last 3 years. He also has CHF with a pacemaker and past history of bypass surgery many years ago. He's hypertensive, which is controlled by medication. He also has high cholesterol. He tends to have recurrent pneumonia and has chronic back pain, which past surgeries have helped but did not fully resolve. Finally, he was recently hospitalized for heart palpitations and was found to be dehydrated. As mentioned before, Mr. Moore was married for 51 years and is widowed for the past 4 years. He still lives at home and is the retired fire chief of the town he lives in. He remains independent in his ADLs and his IADLs. His immediate neighbors know him very well, but he now mostly keeps to himself and stays home much of the day. Mr. Moore has one adult son who is married with no children and who lives about 20 minutes away. When administered the PHQ-9 on intake, he scores a 12, which is moderate depression. He denies depressed mood but appears sad. He also denies some of the other psychological symptoms such as low self-esteem or suicidal thoughts. But he did endorse physical symptoms such as sleep difficulty, fatigue, and decreased appetite. He also reports lack of enjoyment in activities, saying, "I can't do much anymore and I don't really care to anyway." He says he used to be enthusiastic about his bird feeders and taking care of his cat, but now he just goes through the motions. When asked about his wife, he appears more sad and his eyes well up a little. He's not taking any antidepressants. While you're doing the home visit, his daughter-in-law is there, and she tells you that she is there most of the week and that he is always like this. She insists that he is depressed, saying if I don't come and take him out, he would stare out the window all day. His son is also there, but he says this is unusual because he is so busy. He thinks that his father is fine, saying he's always been like this and can tough things out. The son believes his wife is over-involved with her father-in-law and that she needs more things to do with her time. They are now looking at you for answers about his depression. So you don't have to take sides in a situation like this. You can acknowledge that they have different opinions about Mr. Moore, and here's where the PHQ-9 can be very useful both to educate them on depression and to provide feedback about their father. You can show them the items of the PHQ-9 and explain that depressed mood is only one item on the scale, and that depression is a clinical syndrome comprised of 9 symptoms. You can provide specific feedback on Mr. Moore's symptoms, pointing out that some are physical in nature, such as sleep, fatigue, and appetite, and some are psychological, such as anhedonia or lack of interest and enjoyment in activities, and sadness and tearfulness that you observed. You can acknowledge that depression can be complicated to identify when other illnesses are present and can be causing some of the symptoms you're observing. And you can suggest that perhaps an appointment with someone who specializes in this area can help clear up this question. In this way, you don't have to take sides, but can instead just provide information, education, and perhaps some suggestions on how they can go about getting this question answered without feeling like you're stepping outside your areas of expertise.